Okay, good morning, everyone. I'm the editor-in-chief of the Journal of BABE, and I've had a chance to see a lot of papers that cross my desk and come to the conclusion it really is a very elegant science, that you can actually compare one drug with another drug without having to do a clinical trial. And you might not appreciate it because in oncology, everything has to go through a clinical trial. The cancer process, the disease process, is easily a decade long. So you can imagine how slow progress has to be. If cancer would run its course in a month, they would have figured it out a long time ago. The problem is the long time scale. Let me describe a little bit on that subject what I have found. Okay. In general, you as I mentioned, you rarely see anything on bioequivalence studies to compare drugs in oncology. The problem is you don't have a good understanding of the disease. You can't just say this drug is as good as that drug if you don't understand the disease process. And I'm quoting here from a paper in Cell from a few years ago. The two mainstay treatments, chemotherapy and radiation, you can read it yourself. In general, they've done a lot of work with biotechnology, but they don't have an understanding of why chemotherapy works, why radiation works, and why it ceases to work. In this environment, it's really hard to imagine that you're going to compare one drug to another drug with the lacking of the actual detailed knowledge of the disease process. What I want to focus on is the use of drugs to prevent relapse. When someone is diagnosed with a primary disease, breast cancer, lung cancer, colon cancer, the process is to remove the primary tumor, and the fear is that the disease will come back in a distant organ where it's much less easy to remove surgically. So extreme efforts are made to prevent relapse. And what they do is they give chemotherapy. In breast cancer and colon cancer specifically, they give intensive chemotherapy for like 6 months at about the limit that you can tolerate. They take you right up to that edge, maximum tolerated dosage, and then they stop and hope for the best. That's really it. It doesn't work all that well. At least in colon cancer, there are 143,000 new cases in the U.S., and 52,000 patients will die of metastatic colon cancer. So there's much room for improvement. Okay, I've made a serious study of the underlying reasons for why they give intensive chemotherapy for 6 months. This is traceable back to papers from the 60s and 70s. I'll just go through them in some little detail. The Gompertzian kinetics is what is usually cited as the reason why they give intensive chemotherapy right away. Gompertzian kinetics is a damped exponential for any mathematicians in the audience. The tumor grows exponentially at small size, constant doubling time, and then gradually slows and stops growing as an asymptotic size. This idea that tumor growth is according to the Gompertzian kinetics has permeated this field, and it's been around so long that people don't realize, where it came from. Let me go through some of that history. Okay, so if tumor growth is fastest when the tumor is smallest, when you remove the primary tumor, presumably any metastatic disease is as small as it's ever going to be and growing as fast as possible. That's the time they give it with the intensive chemotherapy. And as I say, the historical basis is from the 60s and 70s, and the principal papers are the Laird papers of the 1960s and Skipper and Schabel of the 60s and 70s. This is the Gompertzian equation. It's presented in graphical form. What I've shown here is the time scale from 0 would be when the tumor started to grow, up to 900 days, so 2-3 years. And the log scale is this is the log scale, 10 to the 0, it's 1 cell, and 10 to the 12th would be a lethal size tumor. 10 to the 9th would be a 1 cubic centimeter tumor, or about detectable. So the clinical range is from right here to here. And this is the invisible range. It's too small to see. But everyone says that this is how cancer grows. So when you find a new cancer, it's growing as fast as possible. And the chemotherapy drugs are most effective when cells are dividing. So that's the inherent reason why they give chemotherapy during the first 6 months. It's not any more complex than that. And the equation, this is a damped exponential. This is exponential here, which means it's constant doubling time, so it's a straight line on a semi-log scale, and it reaches an asymptotic point. And the blend between the exponential and the asymptotic point is the Gompertzian equation. Okay, I made a study of this. This is going back to when I first got, I made a career change from studying physics to studying breast cancer, and I had a chance to review the entire literature of how this happened. And if you chase down the experimental evidence why the oncologists consider tumor growth to be Gompertzian, you'll always arrive at the Laird papers. I've read all these in detail. And I think I'm the only person who has ever read the entire Laird studies. These papers have been referenced about 1,000 times. And I think that no one's really looked at them because there's such significant flaws in the Laird papers that it's embarrassing. I'll show you that. So Laird measured a growth of 19 examples of 12 different tumors of the rat, mouse, and rabbit, and made the statement: the pattern of growth defined by the Gompertzian equation, Gompertz equation, appears to be a general biological characteristic of tumor growth. I mean, because they used rodents and a rabbit, they say it was multiple species, so it's a general idea. With this statement, you say all cancer growth is according to the Gompertzian equation. So it's a small study, only 18 rodents, and I'm going to show you there's some significant mathematical flaws in the Laird papers. This is the Gompertzian equation. It's an exponential with a damping. So as time goes on, this thing becomes, well, at very small time, it becomes e to the a times t, and at very large time, it becomes e to the a over b. So this has the property of being exponential at small size and a constant value, an asymptotic value at large size. What's very important about the exponential equation is that you can always expand an exponential equation in a series. An exponential can be e to the e minus x is 1 minus x plus x squared, or 2 factorial minus x cubed, or 3 factorial, on and on. This always works. This is always a good approximation. But every time you do it, you check and see if the next term is worthwhile considering. If you want to do a real detailed examination, say you want to get down to the 3rd decimal place, then you evaluate these terms and terms until you get to the 4th decimal place, and you say, I'll ignore those. Then that's a reasonable approximation. What Laird did was just took the first non-zero term. And since this part here is 1 minus that, this 1 goes away, so the first term is that single x. So Laird said that the equation that it's a female, I'm going to use a female pronoun. So she used the first non-zero term as an exponential. I'll show you that. Okay, this is one of the figures from the Laird papers. So Laird this is one of those 18 rodents and 1 rabbit. And these data points are actual measurements on that tumor. You see the time here is, this is 3 months, 4 months. Is this months or hours? I can't see. Months? Yeah. So this, it was a slowly growing tumor, and this is the size of it in, I can't quite see what the scale is. You see here, Laird fit a data aligned to the Gompertzian equation to these data, and then said, let's compare it to an exponential growth. And the exponential growth was taking that first term in the approximation, which is always going to be larger. The next term is going to be smaller and larger, smaller and larger. Pretty soon you get to the exact figure. But using only the first non-zero term in the Taylor series, it's always going to be larger. So Laird said, I am comparing the Gompertzian equation with an exponential curve, and the Gompertzian is better. I mean, it's nonsense. This is a mathematical identity. This has nothing to do with cancer. So this flaw, this mathematical flaw, is repeated 18 times. This is another one of the Laird figures. This is the Gompertzian fit, and this is the exponential. And you see they fit at the bottom, and then the exponential is always larger. This has nothing to do with cancer. This is always going to happen. So Laird, on the basis of 18 flawed figures like this, said that the Gompertzian equation is superior to the exponential growth. Therefore, cancer grows Gompertzian. That's why they use Gompertzian to describe cancer growth, and that's why they give intensive chemotherapy as high as possible the first 6 months and hope for the best. It's not any more complicated than that. I've read all the papers. Okay, now we're skipping to Skipper and Schabel. Skipper and Schabel did some very important work with animal models. They took multi-passage animal tumors with really fast growth. They used a 1-day doubling time tumor or a half-day doubling time tumor. The tumor grows from 1 cell to 10 to the 9 cells in 30 doublings. 2 to the 30th is 10 to the 9th, approximately. So 30 doublings, you can get a tumor from 1 cell to a detectable tumor. So if you used a half-a-day doubling time tumor, in 15 days you can do an experiment. It's great for experimental work, but a human cancer has doubling time of 100 days or 120 days, which is far different. So they use this murine leukemia, and they found they can cure their animals if and only if they could kill every last cancer cell. And the drugs they used were toxic. They used the terms of LD50 and LD90, which means that this drug was lethal to 50% or 90% of the animals. But if the animals survived the drug and they were able to kill the last cancer cell, then the animal would survive. This has been translated into modern oncology. I'm sure it sounds stupid to you, but that's about right. They cited the Laird papers and said tumor growth was Gompertzian, and the Laird papers have been cited about 1,000 times. And I don't think any of those 1,000 people actually looked at the Laird papers in detail, or had the mathematical background to smell out the errors. And the Skipper-Schabel papers have been cited 2,000 times. I mean, this is the fundamental idea underlying why they give adjuvant chemotherapy. Okay, here are some of the Skipper references. You can look them up. The years are 1964, 1970, 1970. So the next question is, how do cancers really grow? If Gompertzian equation doesn't do it justice, how do cancers grow? It's really important. This is a paper that I dug out from JNCI in 1961. These are animal tumors that they were not injected. These animals have a predisposition to having cancer, so you don't have to have 100 animals to find one tumor. But there was no, they did not inject cancer cells. These are naturally occurring cancers in animals predisposed. And you can look at how the way these tumors grow. This one has an S shape, this is a straight line, this is an upward sloping, this goes up and down. You know, I'm pretty good at fitting equations to data. And it would be foolhardy to try and fit an equation to this. I mean, tumors get larger over time. They tend to get larger over time. Sometimes they get smaller over time. But they tend to get larger over time. That's about the best you can say of a natural cancer. Gompertzian equation doesn't work here. And maybe this one is a Gompertzian equation, and maybe this one is, this one's not, that's not. Yeah, they do anything they want. They tend to get larger. That's the best you can say.
About 1/3 of this Gompertzian equation?
1/3 of Gompertzian? Well, I think there are 20 or 30 here. 6 times 636. And I can see in Gompertzian, I see 1, 2, 3. Maybe this one's going to roll over 4, 5. Maybe this is 6, 7. Maybe 7 out of 36, you could say, is Gompertzian. That's not enough to say that the Gompertzian equation describes cancer growth, and I'm going to treat every cancer patient according to the Gompertzian equation. Okay, so this is personal. I had been studying cancer growth for a while, and I happened to get diagnosed in 1995 with stage 3C colon cancer. And this was a high-level cancer at high risk of relapse. I had the primary tumor removed, was no big deal. But I needed chemotherapy, and the only drug available was 5-fluorouracil. This has been used for colon cancer for many years, and I had to make the decision. I needed chemotherapy. How was I going to do it? I had this knowledge of the Gompertzian equation and the Laird papers and Skipper and Schabel. I knew the flaws in that. I still needed chemotherapy. So what to do? I went through some simple logic. I said, let's take an approximation. Let's take the best possible configuration. Let's say that the cancer growth is orderly. That is, every single cancer cell in that tumor doubles once and only once in a doubling time. It marches like soldiers in a parade. They're all marching. And the other approximation, let's say the drug is 100% effective. Every time a cancer cell tries to divide under therapy, it's toast. That's the best possible configuration. And under this approximation, how long should chemotherapy go? And the simple answer is 1 doubling time, 1 volume doubling time. Every cancer cell will be eradicated. And for metastatic colon cancer, the volume doubling time is 2 to 3 months. So, you know, under the most ideal considerations, you could say chemotherapy should be intensive for 2 or 3 months. And then I calculated, I said, well, they're not, the drug is not perfect, the tumor is not orderly, let's use reasonable approximations. And I came to the conclusion that the therapy needs to be at least 2 years. And that puts limits on it. You can't take a toxic therapy for 2 years. So with this simple logic, you came to the conclusion that chemotherapy has to be given over 2 years and has to be non-toxic. So that's what I used. I used a low dose 5-FU every night for 2.5 years, non-toxic level. I mean, I didn't have any symptoms, any toxicity at all. I didn't miss a day of work. I didn't have an aspirin. I didn't have a headache, no nausea. So I published this. I published this whole idea of my therapy. This therapy is now called metronomic chemotherapy. I already talked about that. So I used this low-dose 5-FU, and at the time it had not been used in early-stage cancer. It had been used in late-stage cancer, never in early-stage cancer. So I used 30% below the tolerable limit, which turned out to be 200 milligrams per meter squared per day, and I was on the therapy for 2.5 years, every night for 2.5 years. And I was on Judah Folkman's staff at the time, and I told Folkman about it, and I said, have they ever tested 5-FU as an anti-angiogenic? And Folkman said, yeah, they tested it. Folkman brought Tim Browder into the room. So in this room was myself, Judah Folkman, and Tim Browder. And it turned out that Browder had tested 5-FU, but only as bolus. And I told Folkman, I said, the half-life of a 5-FU bolus is 20 minutes in the body. You can't expect it to show any anti-angiogenic property. So then Browder tested it in mice with a portable pump. So they had mice and tumor-bearing mice, and they used a portable pump. And they found out that, yes, indeed, if 5-FU was given at low dose for a long time, it was anti-angiogenic, slightly. So Browder published a paper, Anti-Angiogenic Scheduling of Chemotherapy Improves Efficacy Against Experimental Drug-Resistant Cancer. This was published in 2000 in Cancer Research. I think this paper has now been cited over 1,000 times. It's now called metronoma chemotherapy. So if you hear metronoma chemotherapy, you know, I'm the guy who sort of started that. Anyway, I published all this. I published metronoma chemotherapy. I talked about the therapy and how long should adjuvant chemotherapy be given in early stage colon cancer. So everything is open, and there was a book written on, Judah Folkman died in 2008. So there was a biography written by Robert Cook. And in that biography, they had a couple pages on my therapy. So just as a disclosure, I'm on the board of directors of the Colon Cancer Alliance, and I have patents pending for treatment of early stage cancer and method of preventing surgery site infections. Okay, thanks for your attention. Thank you for your questions. Yes?
So how often now the measurement therapy has been used clinically these days?
Yeah, it's been slow to use. It's this drug 5-FU is less expensive than sterile water, so there's no money in it. You know,
that's why there's no driving of this course.
If it was an expensive drug, you know, there would have been testing. It's slowly getting tested in late stage disease, but this is an ideal therapy for developing countries. This is a $1 a day therapy.
Yeah. So my mother-in-law had diagnosed colon cancer, also stage 3 last year.
Yeah.
I had consulted 2 colon cancer experts and one in China. None of you brought this up. You know, she has intensive. She's almost 80, but she has intensive 6 months chemotherapy. Really difficult.
Really tough on her, huh?
Yeah, very tough. But you know, nobody would mention this option.
Yeah, I mean, it's been 17 or 20 years since I used it, and it's still not, you know, properly tested as it should be.
Yeah, and maybe there are more aggressive testing to really make people more aware of this.
Hopefully something. Yes.
Are some trials being conducted to use the metronome therapy?
Not proper trials. I mean, the proper trial would be, I described in one of those papers that stage 2 colon cancer actually has a fair relapse rate, like 15%. And it would be reasonable to use this therapy in stage 2 because they don't normally use chemotherapy anyway. So the controls would have at least as good as standard therapy. That has been proposed. I don't know if it'll ever happen. I mean, it's 17 years and it hasn't happened yet, so I'm not optimistic. Okay. Thank you. Thank you.
Thank you. I'd like to announce the Best Poster Award. It goes to Syed Ali. Dr. Retsky is going to